Let me welcome on my guest, Dr. Ralph Alvarado. He's practiced medicine in Winchester, Kentucky since 1998. Currently serves as a member of the Kentucky Senate from the 28th District out there, being first elected in 2014. He's the first Hispanic person elected to the Kentucky General Assembly. His father was from Costa Rica, and his mother is from Argentina. And welcome to Dr. Ralph Alvarado, sir.
Thanks, Chris. Thanks for having me on your show.
You are suing, this is fantastic news, you are suing the Secretary of Health and Human Services, a man that Joe Biden calls Javier Baccaria. His real name is Javier Becerra, and the Centers for Medicine and Medicaid Services and the administrator, Chiquita Brooks. Why are you doing this?
Well, it's kind of an interesting story. Basically, I'm a practicing physician. We serve a part-time legislature here in Kentucky, so I continue to practice medicine to serve doing public service. But, you're always looking for an opportunity as a physician. There's opportunities to help generate more revenue. And I had a colleague say, hey, there's going to be an opportunity through HHS. They do things like accountable care organizations and trying to provide better quality care, et cetera. And I thought it was something along those lines. What they made me aware, though, is that they said, hey, listen, we're going to incentivize doctors to get more money, basically, if you provide us kind of an anti-racism plan for your practice. And they would want me to basically prove to them that I'm not a racist with my patients, that I'm supposed to provide a disparities impact statement. And they actually asked me, what population will you prioritize to, help provide kind of non-racist care to patients? And I'll tell you, and I've been practicing now for 24 years. Basically, I don't know of any doctors, nurses that I've ever worked with that have a racist bone in their body. We take care of people that come in. We look at them when they come in. I don't worry about, if they're black, white, red, yellow. When they call me, what's their name, what's their age, what's their diagnosis list, what medications are they on? Here's the test that I want ordered. I do examinations on those folks. And when I come in to meet them, that's when I find out what race they are. But it doesn't typically impact my care for them. I mean, there are certain disease states that are probably more prominent in certain groups due to genetics. And there are some slight differences on medication treatments for certain things. But the first thing that I do is I don't ask the first thing, hey, what race are they as far as care? And so what this is going to do is people like myself, who's still an independent doctor, I'm not going to do this. I refuse to do this. I think it makes me inject racism into my practice, which I don't currently have. And, and what's going to happen is there's a lot of other doctors, most doctors these days, who are a part of a corporate medicine, if you will. I mean, a lot of they're owned by hospital systems, they're employed by hospital systems. And those systems, for fear of being labeled racist, are going to comply with this. And when they do, they're going to create another level of bureaucracy for providers. And it's going to basically mean that I get less reimbursements if I don't choose to participate in this than others that will. And so that's what we're suing, is to put a stop to this. I think this, it's gotten to the point where it's bad enough how much government is already in healthcare. This is just adding another level of bureaucracy. And you talk about burnout for doctors. I mean, I think this is just going to add to that level of burnout for doctors to have to worry about these kinds of rules being put into place to get paid for your services.
No kidding. And so what stood out for me in your description was that they wanted to hear your plan to serve certain races over others. They wanted to hear your plan to execute that. So the implication is that you need to serve people of color over whites, and you need to show them how you're going to do that to get your money. Am I misrepresenting that in any way?
Yeah, no, I mean, what they're basically doing is, and again, I specialize in a lot of long-term care. I do a lot of nursing home work. And so, my patients are covered by Medicare. But what this basically is doing is it's a federal rule, and it was implemented in January of this year, and it explicitly aims to, and I think I'm saying this right, quoting, address systemic inequities, including systemic racism in healthcare. But it doesn't describe anywhere as to what those inequities are or describe what form that racism takes.
Does it provide proof?
And they're basically financially incentivizing me to look at my medical practice and patients through the lens of race. And where I come from, that's not anti-racism, that is racism.
Well, no, I agree. It is racism. Yeah. But, Doctor, did the government provide any proof that systemic racism exists in American medicine?
No, they don't. They don't tell me what they view that racism as or where the inequities lie. And we know that there's healthcare disparities. We know that there's proof of that within the healthcare system as a doctor. And I'm the chairman of the Health and Welfare Committee in our state Senate. I mean, we see those things. We study those things. But those things are not due to inherent racism from our providers. It might be from issues like poverty, education, transportation issues, access to broadband. And we work on those things as a state and as government to try to level that playing field for individuals. But those situations, at least in the state of Kentucky, we've got urban and rural areas. The west end of Louisville, which is predominantly African-American, there's a Hispanic population there as well. They encounter those disparities. But so do the people in eastern Kentucky and Appalachia, which are all white for the most part. And so, the disparities are very similar in both of those groups. So the reasons are not from race. It's due to access. It's due to, again, transportation, poverty, education, et cetera. Sometimes cultural differences on perception of healthcare. But they don't tell us what they are. They just say, hey, we're going to try to fix this. So, doctor, we want you to tell us what population will you prioritize. You're going to issue a disparities impact statement. And I'm going to use one that they provide, rather, and then try to prioritize the particular needs of people based on what their race is, and kind of show to the government, hey, this is what we're trying to do. And I, for me, it's number one, it's impersonal. You're putting people into populations and saying because of race, everything there is, this is how we're going to treat you, when in reality, healthcare is incredibly individual for each individual patient, and typically regardless of race. And so, they want me and they would want my team also and people around me to undergo training to identify implicit biases and underlying racism. And I consider that insulting to the extreme. Because again, like I said, in all my years of medical training and practice, I've never had a doctor, nurse, other medical professional who was racist.
Yep.
We've always looked at trying to affect that patient and get the best outcome that they desire for their own health care, and that's what we always work on.
This is This is government-imposed racism, and it ought to be fought. Dr. Ralph Alvarado is our guest right now, folks. So let me ask you this. All of the stuff that you're describing, who shoulders the expense of all of this, the training, the plan? Who is, am I right in assuming this is an unfunded federal mandate?
Of course. Well, what they're labeling it as an incentive. So they're saying, well, we're not going to charge you if you don't do anything, but if you want more money from us, you'll do this. So they're trying to label it right now as an incentive. And again, the majority of doctors are now employed, and given their constant search for revenue, administrators of hospital systems are going to quickly give in if they haven't already, and the doctors themselves won't have much say. So complying with an anti-racism plan means more bureaucratic hassles that are already driving tremendous burnout. Calling doctors biased and racist really won't help things either. And a lot of my fellow independent doctors, the promise of higher revenue is often hard to turn down, given the financial pressures we already face in medical practices. But the cost of the practice of medicine will be steep if race is allowed to dictate patient interactions and care decisions. So I think it's gone to the time where I looked at this. I said, okay, I'm done with the madness of this. It's time to start doing something. And reached out to an organization that's a nonprofit organization that is called First Do No Harm, and they've essentially teamed up with us. It's another doctor in Mississippi who's also outraged by this, and that's when we filed lawsuit to put a stop to this.
Let me ask you to put your medical hat on, because I think this all dovetails with the politicizing of medicine. This is what happens when socialists are in charge. They inject left-wing politics where it doesn't belong, national security, and in this case, medicine. The FDA has just issued restrictions on the Johnson & Johnson China virus vaccine due to blood clots. Now, for the last year, we've been talking about and being censored by the federal government and by social media companies for saying there are increased cases of blood clots associated with some of these vaccines. Now, all of a sudden, since the FDA comes out and says it, now it's permissible to talk about. Yeah. This is the problem with people who are forced to basically take vaccines to keep themselves employed, and the suppression of actual risks to people's health. Isn't this a problem with left-wing Democrats, socialists politicizing medicine?
Yeah, and I'll tell you this, we need to allow, and again, this is the criticism I had from the beginning of this entire situation. At least here in Kentucky, our governor kind of acted like a king and started issuing edicts, did not involve the legislature. And it's one thing when there's a pandemic starting, people are uncertain what to do. You need to have somebody kind of directing things, but he didn't have any really restrictions on how long those oversights could occur. He basically just said, we're going to be in an endless state of emergency, and I'm going to tell you what to do. Well, finally, at some point, the General Assembly stepped in and put a stop to that, and we went ahead and blocked it, and so you only get 30 days of this. But we also passed a law saying that you're not going to be forced by anyone to do a vaccine if you don't want to, so that people could say, look, I don't want to have a vaccination here in Kentucky. They don't have to. It doesn't matter if it's a state of emergency. You can refuse and say no. Now, I've been a pro-vaccine guy, but I've watched the science as this stuff has come through. And so when the Johnson & Johnson vaccine came out, there was a lot of discussions about blood clots, particularly in young women at that time who were of childbearing age or on birth control, so they had higher hormone levels, had a higher risk of clotting with Johnson & Johnson. So when people would reach out to me saying, Doc, what should I do? You know, you're my friend. I trust you. Should I take a vaccine? Should I not? You know, have you had the virus? If you've had it, you probably have a high enough antibody level. You know, you can wait a while and see if new variants come out. And we would have these discussions, and I would have that interaction with patients saying, look, the messenger RNA one, it's a newer vaccine. It's technology that's been studied for a while, but here are the risks. Here's what we know. And I would inform people. And that discussion for them was more valuable because they didn't trust the government telling them things. And they wanted to have a discussion with a doctor who's actually looked at some of the studies and seen, hey, if you're this, I wouldn't recommend Johnson & Johnson, but here's the risks. Here's how it's manufactured. Here's how it's done. And I think from the beginning, we should have allowed our medical community to take the lead on that and not government agencies saying this is what you have to do or not do. And you're right. I mean, to suddenly turn on a switch and say, well, we say it's okay, so now it is okay, it destroys the trust that people will have in healthcare and even with providers sometimes, you know, because people feel like they don't have control over you know, the decision of taking a vaccination or not, or accepting a kind of treatment or not. I tell people as a doctor, I give advice all the time, you know, to patients. They take it sometimes, and sometimes they don't. And my ethical code requires me not to judge people, not to chastise them, not to humiliate them, not to say something about them if they don't agree. You know, if I say, hey, you shouldn't smoke, and a person says, okay, well, I'm going to keep smoking. Okay, it's not good for you, you know, but they know, and they're informed, and they get to make that decision. If they have a bad outcome because of that, I don't rub it in their face or humiliate them or say something and, you know, to try to demean them for it. They know why the result is, and then we have a new diagnosis, we have to treat this and move forward. That's what we're supposed to do as medical professionals and doctors. That's what our patients expect from us. And when the government wants to become the doctor and say, we know what's best for you, you'll do as we say or else, that's a major problem. And it's one thing to inform and say, here are your risks. Here's what we know, you know, but healthcare at any point in time is not black and white. It's a preponderance of evidence or preponderance of knowledge at that point in time. A lot of things that we did 100 years ago in healthcare that today we would think is quackery, but it was modern science at the time. That's what we knew. But as we learn more and develop more, so everything should be considered in that lens. And, you know, unfortunately, when it comes to government, it becomes black and white and right or wrong, and they're the ones who think they can determine that. And I think, you know, you should let our medical community speak their minds. You know, science is advanced by developing a hypothesis, proving it right or wrong. There's criticisms from studies. That's how healthcare has always been, and doctors have always been that way. When you produce a study, some will agree, some won't. And there's differing opinions, and that's how you advance medicine.
Well, for the first time,
so it's a shame that this has gotten so politicized the whole way through. But at this point, like you said, now it's been found to have complications. And, you know, there were people saying that from the beginning.
That's exactly what my broader point was, is that for the first time, we've accepted Democrats getting between us and our doctors. And it's like, I wonder sometimes what country I woke up in. Last thing I want to ask you, masks. Outside of a clinical setting, what do the studies that you have read, and I've read some of them too, published peer-reviewed studies, what is the final ruling on masks? Do they actually prevent the spread of the China virus outside a clinical setting, or do they not?
Yeah, so there's different studies of different types of masks. I think cloth masks have been found to not really provide much protection. I think the studies that I saw reduced spray, you know, so actual, you know, when you talk, spit will come out and that sort of thing. And so that can be a contaminated liquid. It restricts that. I think they did some studies. That's why they came up with the 6-foot rule and all that, is that if they put that on, it would restrict how far that could spray with people, et cetera. But cloth masks really, I mean, in terms of this is so aerosolized, I think now looking back, it didn't do much. What you needed to have was an N95 mask that was properly fitted. And, you know, listen, as I was a medical student back in the 90s, being trained, we were fitted for N95 masks and very securely fitted, and they were personally fitted for each individual for tuberculosis, because tuberculosis is still rampant in the world and still very contagious. And when they exposed it to us, they made sure that we couldn't, you know, smell smoke through it. It was very protected, very tight, and we would see TB patients. We were required to wear those to go in to see them. Yeah. So in that regard, those work. N95s, if they're properly worn, will reduce it. The cloth masks, no, I think they've been shown now that they don't really do much. And I think we knew that from the beginning when Dr. Fauci first started. You know, people wanted to wear those. He said, please, no, they don't work. They don't do much. Don't use them. And then it became a different set of rules. And so I think the most recent data we have is that the cloth masks don't do much as far as transmission and spread. N95s are what you need to wear if you're going to reduce spread.
Well, keep us posted on how your lawsuit goes, because injecting race into medical care, unless it's genetically pertinent, as you described, I think is wrong, and it's wrong on the federal government to do social experimentation in medicine. Haven't they ruined medicine enough by Obamacare? Dr. Ralph Alvarado, he is a practicing physician, 1998. He's been in Winchester, Kentucky. He is part of the assembly there in Kentucky. Sir, appreciate the time.
Thanks, Chris. I appreciate being on.